Welcome to the Module 5 of the Pediatric Sedation Anesthesia course. I'm Gary Badger, Professor of Pediatric Dentistry at the UT Health School of Dentistry at Houston. We're welcoming you back to the continuation of this program. I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you will receive instructions regarding taking the exam. This section presents information to create an understanding of the continuum of sedation through which the dentist can make appropriate choices of pharmacologic agents that can be safely and effectively used for various pediatric dental sedation procedures. This course is part of a 16-hour comprehensive program designed to meet the requirements of Texas State Board Dental Examiner Rule 110.17, Sedation Anesthesia of Pediatric Patients. Module 5 is to give you information regarding informed consent by the parent, guardian, or the caregiver. Upon completion of this course, you will be able to understand the purpose of consent, provide timely verbal and written consent for planned procedures of their patients, execute the consents as provided by the laws of the jurisdiction in which you practice. The law generally has several criteria for selecting information to provide to a patient or a parent as part of an informed consent. Some states follow a patient-oriented standard that information which a reasonably prudent patient or parent in the same or similar circumstances would wish to know, and other states follow a practitioner-oriented standard that information which a healthcare provider practicing within the standard of care would reasonably provide to a patient or parent in the same circumstances. A hybrid approach, combining the patient-oriented and practitioner-oriented standards, is followed by some states. Regardless of the standard a state is chosen to follow, the treating practitioner must disclose information that he or she considers material to the patient's or parent's decision-making process and provide a warning of death or serious bodily injury where that is a known risk of the procedure. In all AAPD oral health care policies and clinical practice guidelines, the term parent has a broad meaning encompassing a natural biological father or mother of a child with full parental legal rights. A custodial parent who, in the case of a divorce, has been awarded legal custody of a child. A person appointed by a court to be the legal guardian of a minor child, of a foster parent, a non-custodial parent caring for a child without parental support or protection who was placed by local welfare services or a court order. Informed consent shall include an explanation of the benefits and risks of protective stabilization, alternative behavioral guidance techniques, and a clear explanation of the anticipated restraining devices, Rule 108.14 of the Texas State Board of Dental Examiners. The dentist must maintain a written informed consent signed by the patient or a parent or legal guardian of the patient. If the patient is a minor or the patient has been adjudicated incompetent to manage the patient's personal affairs. A signed written informed consent is required for all treatment plans and procedures where a reasonable possibility of complications from the treatment plan or a procedure exists, or the treatment plans and procedures involve risks or hazards that could influence a reasonable person in making a decision to give or withhold consent. Such consents must disclose any and all complications, risks, and hazards. Again, Rule 108.7. The patient, parent, guardian, or caregiver must be advised of the risks associated with the delivery of nitrous oxide oxygen, inhalation sedation, and must provide written informed consent for the proposed sedation Rule 110.3. Informed consent shall include an explanation of the benefits and risks of protective stabilization, alternative behavior guidance techniques, and a clear explanation of the anticipated restraining device, Rule 108.14. It is generally understood that the person granting consent is the patient of the age of majority. For patients under the age of majority or adults with diminished mental capacity, informed consent should be obtained from a parent. Informed consent and informed refusal forms should be procedure-specific, with multiple forms likely to be used. Statutes and case law of individual states govern informed consent. Some states allow oral discussions, which should be documented in the medical record, while others may require written consent. Oral health practitioners should review applicable state laws to determine their level of compliance. Consent forms should be procedure-specific, utilize simple terms, and avoid overly broad statements. Reasonable foreseeable risk and discomforts. This includes undiagnosed dental and medical conditions. What this means is that patients often are very young when they are anesthetized or sedated. And when this occurs, there may be situations where physical conditions, medical maladies may be present in the child that have not been diagnosed or have been suspected but not clearly documented. And because of this, it's important to have this discussion with the parent that these undiagnosed dental or medical conditions could be risk factors for the child who is undergoing a sedation protocol. It means that there may be things going on within the patient that have not been formally diagnosed and may lead this child to either have inadequate respiratory or cardiovascular or renal or liver or any other kind of medical condition that has been undiagnosed and may pose a risk for this patient who is potentially going under sedation. The benefits of the proposed procedure needs to be continued in the elements of informed consent. The benefits generally include the stopping of tooth decay, the elimination of cavities in teeth, the restoration of proposed teeth, the application of space maintainers and space regainers in situations where early tooth loss was part of the treatment plan and the progression of the treatments. And because of these, it's important that the patient know what the benefits are and that they clearly understand that they are necessary to maintain arch length integrity, keep the patient on a track of developing their primary and permanent dentition to a point where optimal functional positioning and utilization continue to occur as the patient develops. Disclosure of alternatives, procedures, and or treatments. Disclosure of alternative procedures might mean, for example, that a patient has a very large amount of tooth decay, and typically in high-risk patients, a stainless steel crown is placed on a child's teeth. Although new methods of providing crowns for children is available, but these disclosures of alternatives might be that stainless steel crowns are not desired by the parents of this individual, and they would prefer a more aesthetic result from the application of the treatment. And therefore, these alternative procedures need to be discussed with the patient and a decision made jointly as to what is going to be in the best interest of the child. And that means that it may be aesthetic fillings, restorations. It may mean that crowns placed on the upper front teeth of children are there to be a more aesthetic result than what stainless steel crowns have been in the past. And it's important to disclose that to the parents so the parents will have a say whether that type of treatment is acceptable. Up until now, there's been no alternatives that are as good as stainless steel crowns for durability. However, the new zirconium crowns available are a adjunctive choice, and it should be explained clearly to the parent to be able to make that choice. The confidentiality of records is an important part of informed consent. Patients need to be reassured, or the parents of patients need to be reassured, that information contained in those records will not be shared with another individual unless that patient participates in the treatment of the child. It's important to be able to reassure the parents that that information won't be shared with other people. And finally, contact information. Contact information is important for continuity of care for the patient. The patient's parents need to provide their information, a contact telephone number or email or media address where these patients can be contacted so that continuity of care can be provided for the patients as they come in to visit with the office. All these elements are important features of informed consent. Informed consent is generally governed by the laws and statutes of their state, and consent is essential for parents, caretakers, guardians, to have control and retain autonomy over the health decisions made for their child. It may also decrease the practitioner's liability from claims associated with miscommunication or no communication. In the state of Texas, 108.7 states the following: maintain a written informed consent signed by the patient or a parent or legal guardian of the patient if the patient is a minor or the patient has been adjudicated incompetent to manage the patient's personal affairs. A signed, written, informed consent is required for all treatment plans and procedures where a reasonable possibility of complications from the treatment plan or a treatment procedure exists, or the treatment plans and procedure involve risks or hazards that could influence a reasonable person in making a decision to give or withhold consent. Such consents must disclose any and all complications, risks, and hazards. In the United States, patients with limited English proficiency have a legal right to access health care in their preferred language. The foundation of this right is established in the Title VI of the Landmark Civil Rights Act of 1964, which prohibits discrimination on the basis of race, color, national origin in programs and activities receiving federal financing assistance. In healthcare, Title VI, as enforced by Executive Order 13166, entitled Improving Access to Services for Persons with Limited English Proficiency, is a cornerstone for the provision of oral interpretation and written translation services to patients with limited English proficiency. Consent forms are subject to interpretation. Consent forms should contain information to patients and parents about the dental health problems the dentist observes, the nature of any proposed treatment, the potential benefits and risks associated with that treatment, any alternatives to the treatment proposed, and the potential risks and benefits of alternative treatments, including no treatment. Consent factors. The practitioner should be aware that the adult accompanying the pediatric patient may not be a legal guardian allowed by law to consent to medical procedures. For example, grandparents, step-parents, non-custodial parents, instances of divorce, babysitters, or friends of the family. In such cases, a copy of the court order appointing a guardian to verify who is authorized to consent for medical procedures is needed. Obtain a proxy or power of attorney agreement for any other individual to make dental treatment decisions for a child. Another option for authorization is a telephone conversation with the parent. This should be told when there are two people on the telephone and asked to verify the patient's name, date of birth, and address, and confirm he or she has the responsibility for the patient. In a typical practice, if it is the design of the doctor to get consent over the telephone when written consent is not available, then the doctor needs to be on the phone with a dental assistant or front desk administrator, and the two people talking to verify that the patient's name is correct, the date of birth is correct, the address is correct, and confirm that he or she whoever's on the other end of the phone, has responsibility for the patient. The patient is presented with all elements of a valid informed consent, followed by documentation in the patient's chart with signatures. Written consent is advisable regardless of state laws. This should be preceded by a thorough discussion. Dentists should be made aware of linguistic, cultural backgrounds to ensure adequate linguistic, competent information has been presented to help parents make informed decisions. Deaf or hearing impaired individuals' self-assessed needs should be considered. Translation or sign language services may have to be provided. In my experience, we've had the opportunity to work with deaf or hearing impaired individuals, and when that occurs, there's either sign language, usually between the child and the parent, who can help with the process. However, if the parent insists, then it's essential that a translation service be engaged to provide the services necessary so that there is a full understanding by the deaf or hearing impaired individual prior to proceeding. Supplements such as informational booklets or videos may be helpful to understand the procedures. Videotapes can be especially helpful in that they will show techniques of behavioral guidance techniques, will show procedures that can be done, the application of crowns on teeth, the fillings that are placed on children's teeth, the reaction of children to dental procedures, the outcomes of certain procedures expressed in the videos, and the ability of the practitioner to provide as much as possible any device or image or media that will help the parent to understand what the procedures are and what the outcomes are expected. Refusal consents must be documented, but do not relieve the dentist from providing the standard of care. And what that means typically is that the parents may refuse to do what is considered average acceptance of treatment, and if the parents may be asking the clinician to deliver care that is not the standard of care. And if that becomes the case, it's important to understand that the clinician, the provider, is liable if they do not provide the standard of care, such as seeking another opinion or dismissing the patient from the practice. If the dentist suspects dental neglect, then appropriate authorities should be informed. General statements such as any and all treatment which the doctor deemed necessary should be avoided. Doctors should avoid downplaying risks of proposed therapy. Consents for sedation, general anesthesia, or behavioral guidance, such as protective stabilization, should be obtained on a day separate from the treatment and presented separately. The reason for this is that it is assumed that patients who come in for treatment and receive the consent forms to sign on the day that they are there implies to the patient that they're being coerced to sign these consent forms in order to receive treatment that day. And to eliminate that perception that individuals cannot receive treatment on the day that they were scheduled because consents have not been signed, it's best to obtain those consents on a day separate from the treatment day and presented and accepted separately and signed well in advance of the treatment day. Consent must be updated as treatment needs change, and that means that if the entire treatment plan has not been given to the patient and new treatment be discovered during the treatment of the area in which the proposed treatment was made, then consent must be updated as that treatment needs is identified and that the patient agrees that those can be done, rather than plowing ahead and asking for permission after the treatment is completed. So that's an important concept to be able to grasp. Patients who refuse treatment is a person's right to refuse all and or a portion of the proposed treatment after the recommended treatment, alternative treatment options, and the likely consequences of declining treatment have been explained in language the patient understands. A patient who refuses to follow the recommendations of the dental provider must be advised of the consequences of the refusal. That is, a patient who may have wanted no metal in their child's mouth, and that it's possible to talk with the patient that there are suitable alternatives to place crowns that are strong and healthy and allow the patient to receive those. And it's important to know that if the patient refuses, that it's still incumbent upon us to deliver adequate care that meets the standard of care for the dental provider and note the informed refusal in the patient's chart. It is recommended to have a patient sign a refusal a treatment form, or if he or she declines a treatment recommendation. In addition, treatments that have performed in other offices, for example in a pediatric practice, it's typical to have patients come in that are getting to be in the teenage years and they still have orthodontic appliances in. And if the parent asks you to remove those appliances prior to completion of treatment, it's important to make a document that says that the parent understands that treatment is incomplete and that the removal of appliances may result in drifting of the teeth and not be in the standard of care that's expected from the addition of treatment from the practitioner. If a patient is referred to see a specialist and refuses the referral, the clinician should document the refusal thoroughly in the patient's chart and have the patient sign the chart or a separate form. Parents have many reasons for declining a recommended treatment, such as inconvenience, fear, denial, or inability to pay for services. If a disease condition is diagnosed and the patient refuses treatment, the doctor may decide to dismiss the patient from the practice. That is the doctor's decision. Informed refusal, depending upon the circumstances, a doctor may not feel it is appropriate to dismiss the patient and may choose to provide alternate treatment as opposed to ideal for the short term. As long as the patient understands the ramifications of postponing treatment and the goals of alternative treatment, liability risks are minimized. Sometimes, however, the best option is patient dismissal. Thorough documentation cannot be overemphasized. Case decisions must be made on a patient-to-patient basis. Informed refusal consent form example. Following is a sample form for the refusal of treatment for periodontal disease. Refusal of treatment, the date must be there, the patient's name must be there. Something that needs to be on this is the date of birth of the patient, the age of the patient. Treatment recommended. A diagnosis of periodontal disease has been presented to me on this date. The disease process and possible ramifications for non-treatment have been explained to me, and I understand the consequences of not allowing this office to proceed with appropriate treatment. The parent has a place to sign, the doctor has a place to sign, and/or hygienist, and a witness is there. In addition, the date at the top is important to note the patient's name and age, or date of birth, or both, is essential to have on the consent form. The consent form consists of the following contents: the legal name and date of birth of the pediatric patient, the legal name in relationship to the pediatric patient, is the legal basis on which the person is consenting on behalf of the patient, the patient's diagnosis, the name and purpose of the proposed treatment in simple terms, potential benefits and risks associated with that treatment, professionally recognized or evidence-based alternative treatments, including no treatment to recommend therapy and risks, place for parent to indicate that all questions have been asked and adequately answered, places for signature of the parent or legal guardian, dentist, and a staff member as a witness. This is an example of a consent form. This is one that has been used in the Department of Pediatric Dentistry at the University of Texas School of Dental Health, and it indicates the treatment has been discussed, all questions have been answered, and there is a consent form signature page that the patient must be able to do. I would recommend highly that when a clinician signs the treatment planning and consent form, that it be done in a legible manner. It's very difficult to prove who affixed signatures if it's not a consistent form on a consent document, and it's important that the doctor be identified as having provided consent adequately to proceed with treatment. The following are a few cases that are used to illustrate what it means to get the proper consent for a patient. In this circumstance, a 3-year-old Caucasian female presented for dental examination, accompanied by an elderly woman. The caretaker filled out the medical history and signified that she was the grandmother of the presenting child. What should you do? Choose the best answer. Well, let's examine the answers here for just a second. She completes the documents and proceeds with care. Is there any evidence here that shows that this grandmother, the caretaker, is the proper person who is legally obliged and qualified to provide signatures for the patient? So completing the documents and proceeding with care for this patient would not be a good option. Ensure that the grandmother understands English. Often parents come in or guardians come in where English is not their first language, and as a result it's very difficult for grandparents who do not understand English to provide for them a typical diagnosis and treatment plan and request for signing consent forms. Therefore, to ensure that the grandmother understands English is certainly not adequate in terms of having the proper documentation to do that. The third choice would be to provide the grandmother with the informational brochures of the procedures. This is a very helpful little bit of information that the grandmother has to be able to understand fully what goes on with the procedures that are expected of this treatment of the child. However, it does not provide information and evidence that this person is the legal guardian or has a power of attorney that will allow this to happen. And therefore, getting a telephone number and calling the mother, if possible, is an important thing to happen. Now, when the phone number is taken and to call the mother, one needs to identify themselves as, I am Dr. So-and-so calling from this office, and we have your child in here today. I'm calling to get verbal consent from you to be able to handle your child and to deliver appropriate care. Can you tell me what your name is, and are you the legal guardian of this child? And if you get a yes to that answer, then you need to document that in the chart. And then you want to find, okay, what is the date of birth and age of your child? And you document that as well. And you call and ask the mother what is the best phone number to verify, or do you have an email address that you could send me information allowing me to use this as evidence as the appropriate person to call. So this case 1 is very important, and it's very important for several reasons. One of the reasons is that grandmothers are often forced to take sides in a divorce settlement, and many times the divorce settlement has resulted in the provision of documents which show who is the custodian for the child. And it could be the grandmother that has been the mother-in-law and not really the person to whom permission was given to take care of the child, or it may be, and you just don't know that. So until you go down this road and make sure that you have good documentation that the person who is signing the documents for the treatment of the child, as long as we know that it is a legal document, then we can rest assured that the case can go on with documented care. You select answer 4, and this is the correct answer, because if the grandmother has no power of attorney with her, calling the mother allows you to get consent with verification, the patient's name, date of birth, contact number. If on initiating the phone call to the mother, the grandmother has a power of attorney with her, you may continue processing. If the grandmother appears to not understand English, then you may contact a translating service appropriate to conversing with the caretaker. You may also wish to provide videos of the proposed procedures or brochures along with the translation so that she clearly understands the proposed treatment. That's the best road to take when getting proper consent of these people. While waiting for the phone call, you learn from the grandmother that she has recently arrived in your town to care for the 3-year-old child because the parents have recently divorced and the child is in the custody of the father, her son-in-law. You should select the best answer. See the grandmother's power of attorney. Does the grandmother have a power of attorney? And if so, that should be a sufficient document signed by the son-in-law that allows the mother to do that, along with a divorce decree which indicates that this child is in the custody of the father. Seek telephone consent from the father. That's a stopgap procedure to do for that treatment for that day. And again, you want to get 2 people on the telephone to talk with the father, understand he is a legal guardian, he declares so, and that this recording may be recorded for the patient, and that the father knows the date of birth, the contact information, and the medical history of what's going on with the child. Call the mother to get consent. Sometimes in a divorce settlement where the child has not ended up with one of the caretakers and you give her a call with a consent request, you may receive a belligerent response that they are not the caretaker, they don't want to be contacted with regards to this child, and furthermore, if it was up to them, they would not give consent for what's going on. So prepare yourself for those kinds of things, but try to find out who is the legal guardian and make a phone call to that person. If all else fails and the treatment that day is consequential, you may wish to ask the grandmother to bring the child back on another day with written consent to be able to do the treatment. And on that consent, you should have the child's name, date of birth, or age, and the consenting adult who happens to be with the child, and get all that information laid out clearly. And finally, to ask for the grandmother's ID. That is proof that the person who presented that day is indeed the custodian of the papers that came from the father, either the consent form and or the power of attorney and or the divorce decree, and all that information together. Or ask for an affidavit that is signed by a witness that indicates that the grandmother is the one that's acting on behalf of the custodial parent, and that you clearly have the information that you need to be able to deliver care to that child. If you answered A, it is incorrect because the child in the custody of the father, her son. The child is with the father, and this is the grandparent of the child, but the mother of the mother. If you answered B, that is correct. The grandmother's son has custody, and you must contact him for information and authorization, either verbal or by document, to continue. If the grandmother cannot speak or understand English, and one of your assistants speaks her language, what can you do? A, can you proceed? Or B, must you stop? Unless your assistant is a certified translator, then she cannot speak to the child or the parent asking permission and consent forms. And if you find out that your assistant does have a certification in language interpretation, you can use her. However, if you as the practitioner does know the language, you will be able to speak directly to the guardian or parent and be able to get consent for the treatment. So your assistance in the state of Texas, it's frowned upon unless you are a certified speech interpreter. If you selected A, you are incorrect, as only the doctor can serve as the interpreter unless the assistant is a certified translator in that language. Case 2. A 6-year-old Asian male presented to your office with significant pain on the upper right side. A medical history was taken, and the patient has a history of mild asthma. He carries an inhaler which he occasionally uses during playground activities. No other significant medical history exists for this child, although he has been to another office where he had his teeth cleaned, and he became very anxious and refused and resisted an oral examination. That office referred him to your office in order for the child to receive nitrous oxide so that the pain could be addressed. The father was present and stated that his son had not been able to eat for the 2 days, and he has an elevated temperature and bad breath. He would like to have his son treated as soon as possible. Can he receive permission to use nitrous oxide on the same day as the diagnosis of the condition? Response A is yes, always. Response B is no, always. Response C is preferably yes with earlier consent, and D is no consent needed. If you selected C, then you are correct, even though it is preferred to have consent done on a separate day. In this instance, a fully informed parent may agree to treatment both verbally and written. If they have the ability to develop an email and they can sign it and send it over to you, or take a picture of it and send it over to you, that should be sufficient documentation to place in the child's chart to be able to take care of this issue for that day. In the future, it would be a good idea to advise them that the grandmother needs to have some documentation indicating that she continues to be a factor in the consenting for the child. After further questioning of the parent, he related that the child had a fever for 2 or 3 days, bad mouth odor, and sores in his mouth. What do you suspect? And will N2O interfere with the condition, and what precautions should be taken? Well, let's go back here and review the history again. After questioning of the parent, he related that the child had a fever for 2 or 3 days, bad mouth odor, and sores in the mouth. What do you suspect? Well, one of the questions you might want to ask is, have sores like this appeared before? And is it appearing on any other portion of the body? If it hasn't or doesn't, then you have the suspicion that this is a localized infection and that it has some pathognomonic signs for identifying what the condition is. For 2 or 3 days, the patient has had some fever, and so that generally calls for using some antibiotics. If you see a draining fistula, that would be the treatment for a draining fistula. The patient has bad mouth odor. Well, typically you find that there may be some treatment in order to be able to resolve that. Oftentimes it could be draining pus, which is making bad odor on the patient. It could be an infectious process, which causes a mouth odor. And then finally, sores in the mouth. If you don't have a draining fistula and you have simply sores in the mouth, and what do you suspect, and what will nitrous oxide interfere with the condition, and what precautions should be taken? If you diagnosed acute primary gingival dermatitis, herpes 1, you are correct. If you suggested that viral protection of the practitioner, family, and patient should be considered along with a mass delivery system, you are correct. Consent must be signed to perform treatment on the child. So when you have this condition, provided that the patient is not in a great deal of pain or discomfort, and it seems to be only related to the lesions in the patient's mouth from the viral infection, then it may be wise to postpone this treatment, as you don't want to have an introduction of the viral particles into your respiratory system and the nitrous oxide, as well as expose the staff to the vagaries of virus in the acute primary gingival stomatitis. So it's not a good idea to be able to do that. Case 3, this is a 6-year-old female who presented for dental examination 1 week ago. Now, the child was accompanied by her mother and father, both of whom were highly anxious that their child had exhibited over dental caries on multiple teeth. We know that when we have mothers and fathers, some of our studies have shown that if the parents are highly anxious, the child is likely to be highly anxious. And so you look with concern about the child who may be very concerned about the dental care on that day because of the highly anxious parents and their anxiety about having treatment done is transferred to the child, and the child is wondering why the parents are so upset about going to the dentist. So the most egregious tooth here was tooth number K, the second primary molar. It's been hurting periodically for several weeks, and the parents were very anxious and nervous about the care she was to hear about. The parents asked if the care could be postponed for 6 months until the patient was more comfortable. However, they were advised that tooth number K was very deeply carious and that a 6-month delay could endanger the life of the tooth. The parents agreed that they would return in 1 week and try to have tooth number K filled, and if it went well, would receive care on tooth number L and seal the permanent molars. In addition to that, one might think these days, with the recent approval by the FDA of the silver diamine fluoride, that this would be an easy way to buy some time if parents were objecting to immediate treatment of their child. SDF is an ingredient that arrests tooth decay and acts as a preventive agent. So if you were to use that 1 drop on 5 teeth in the patient's mouth, it would arrest the tooth decay and within the next week or 2 bring the patient back for a second application, and you could put that on. It would stop the tooth decay process dead in its tracks. The disadvantage of using silver diamine fluoride is that it tends to cause the tooth to turn dark to the point of being actually black all over where the tooth decay is present, and if you put that on the child, it will make wherever the caries is very dark and unaesthetic. So if that's one of the issues that you have, you may have difficulty in having the parents agree to that one procedure. So the parents presented a week later, and the child was even more apprehensive, as well as the parents. The treatment plan was explained, and nitrous oxide was reused to reduce apprehension. With some effort and coaxing, the child received a topical and 0.9 cc's lidocaine 2% 1 to 100,000 epinephrine in an inferior alveolar nerve block on the lower left. The patient became more upset when the dental dam was placed in addition to the nitrous mask, and became vocally upset and refused to sit still. After 30 minutes, it was determined that the effort would not be successful and the treatment terminated. The child became most upset when the dental dam was placed in addition to the nitrous mask and became vocally upset and refused to sit still. After 30 minutes, it was determined that the effort would not be successful and the treatment terminated. This is a case where silver diamine fluoride will be an excellent adjunct to do that. Putting the patient into a knee-to-knee examination, active stabilization, it would be possible to at least paint the offending teeth with the silver diamine fluoride and thus arrest the tooth decay and buy some weeks, maybe months, for this child to be relieved of the pain and discomfort and to move on to restorative care when the patient became more cooperative. Parents were given alternatives to IV sedation and or hospitalization, silver diamine fluoride and a temporization. However, the child refused to agree, and the parents asked for her dental records. It's evident when you have parents ask for dental records that they are going to seek care elsewhere, and you would really like to be able to service this child as much as possible. However, if the parents become insistent upon providing care to their specifications, it may not be the patient for your practice. The parent was informed that she would need a specialist to help perform the treatment, yet the parents insisted they would find someone that could treat the child. The parent was asked to sign a refusal to treat form and provided the records to the parent. What would you have done? Well, we've outlined a couple of alternative procedures that are meeting the standard of care and still would be available to help the patient. It will stop the tooth decay process and would relieve that, and this would be something that would be worth discussing with the parents if they would want to delay treatment for this patient. If you have any need for clarification, further information about the treatments that we have proposed, don't hesitate to send an email to pace@uth.tmc.edu. This is a list of references which you may have seen before. And it's important that you understand that the information put together for this educational online course was taken from these references, and these references you are encouraged to go back to and take the opportunity to read each one of these, because they emphasize a point throughout the course that will be useful to help you justify some of the treatment that you provide for the child. This completes this section of the course. It's time for you to take a short exam in order to complete the requirements for streaming video courses. Due to the nature of our subject content, a passing score of 80% is necessary in order for you to advance to the next section. Upon a successful completion of this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, you will be instructed to take the exam, and a new set of questions will be provided. You'll have 3 chances to fulfill the requirements. If you're not successful, you will be instructed to review this section again. Good luck on the exam. If you're ready to take the next section upon completion of this exam, you will be provided a link to continue. If you wish to proceed at a later date, you will need to log in, and no further payment is necessary since this is a continuum.